Welcome to The Explainer. Look, today we're operating at the absolute razor's edge of clinical gastroenterology and hepatology. In high acuity scenarios, hesitation is your worst enemy, and going with your gut feeling over raw data, that's going to lead to catastrophic outcomes. So, we're building a hyperdense mental framework to help you make the exact right call every single time. Let's get right into it.
All right, picture this scenario. You've got a cirrhotic patient with 10 ascites. Serum albumin is 3.4, ascites albumin is 1.2, and the PMN count in the fluid is 310. So what's your immediate intervention? This high acuity situation demands instant fluid analysis over some simple outpatient diuretic adjustment. If your first instinct was just to push more furosemide, we need to recalibrate right now.
The beauty of this is how strictly mathematical it becomes. We map the exact biochemical parameters using the SAG, the serum ascites albumin gradient. You just subtract the ascites albumin from the serum albumin. If that gradient hits 1.1 or higher, boom, you're looking at portal hypertension, like cirrhosis or right heart failure. Strictly under 1.1, you're dealing with non-portal etiologies like peritoneal carcinomatosis or TB. That one simple subtraction problem instantly dictates your path.
Now here is the magic number you need burned into your brain, 250. Going back to our patient with a PMN count of 310, an ascites neutrophil count at or above 250 is a hard red line. It dictates the immediate, non-negotiable execution of empiric IV cefotaxime. You do not wait for cultures. At 250, you have a confirmed diagnosis of spontaneous bacterial peritonitis, and you act.
But wait, antibiotics alone aren't going to save them. You absolutely must administer IV albumin on day 1 and day 3. Literally do not skip this. SBP triggers massive vasodilation. Expanding that intravascular volume with albumin is your only way to mitigate the fatal trap of hepatorenal syndrome. You're basically throwing a shield around the kidneys to protect them from the systemic chaos in the abdomen.
Here's what that raw data looks like in the wild. You get the fluid analysis back. 900 total leukocytes, 67% segmented neutrophils. Do the math. That puts us way over our 250 threshold. This profile forces the immediate initiation of antibiotics to prevent rapid decompensation. There's zero gray area here.
Let's apply that exact same strict logic to acute variceal hemorrhage. Imagine a cirrhotic patient presenting with massive hematemesis. Blood pressure is absolutely tanking at 90/50. Initial hemoglobin is 7.4. What is your transfusion target? The hemodynamics here demand an unyielding restrictive transfusion strategy. The target is 7. You restrict packed red blood cell allocation strictly to thresholds where hemoglobin drops below 7 grams per deciliter. In our scenario, the patient is sitting at 7.4. So, as counterintuitive as it feels, you hold off on the blood.
Instead of reaching for blood, you manage this hyperacute situation by deploying an exact 5-step sequence without a single deviation. 1. 2 large bore IVs. 2. Hold that restrictive transfusion threshold of 7. 3. Start continuous IV octreotide to clamp down on splanchnic vasodilation. 4. Prophylactic IV ceftriaxone, because these patients are at massive risk for bacterial translocation and SBP. And 5. Prep for urgent upper endoscopy within 12 hours.
If you're wondering why we're so incredibly strict about that hemoglobin threshold, just think about the plumbing. Portal hypertension drives venous decompression into fragile submucosal esophageal vessels. The fibrotic liver acts like a literal brick wall to blood flow, forcing it to bypass up through the esophagus. The result? High-pressure rupture.
This is exactly why liberal transfusion is a fatal trap. Aiming for a normal hemoglobin above 9 is strictly contraindicated. Why? Because transfusing variceal patients back to normal overfills a compromised, broken system. It fatally spikes their portal pressures, blows out the clot, and causes immediate rebleeding. You have to respect the fluid physics.
Right, let's pivot to acute pancreatitis. To manage this properly, we isolate the diagnostic triad. You only need 2 of these 3 criteria to confirm it. First, severe epigastric pain radiating to the back. Second, lipase or amylase at least 3 times the upper limit of normal. Or third, characteristic cross-sectional imaging. Hit 2 of those, and you've got your diagnosis.
Next, you take the diagnostic fork. An ultrasound gives you an immediate visual on biliary obstruction, like a clear gallstone with posterior shadowing. That instantly differentiates it from other causes like alcohol use or hypertriglyceridemia, which generally only triggers pancreatitis when triglycerides spike over 1,000.
Now listen closely, because this is a massive clinical trap. Say your patient meets the criteria. Severe pain, lipase is sitting at 4,000. Do you order an early contrast CT scan in the first 24 to 48 hours? Absolutely not. It is strictly contraindicated. Exposing an intravascularly depleted patient in nephrotoxic contrast just to look for necrosis that hasn't even formed yet, that is a critical error.
Your immediate priority shouldn't be grabbing a high-resolution picture of the damage, it's aggressive fluid resuscitation. The pancreas is literally auto-digesting, causing massive fluid shifting. You need to keep those kidneys perfused and strictly track urine output. Skip the stat CT entirely.
So reconciling all these disruptive clinical traps means aggressively adhering to absolute biochemical thresholds across the board. We mitigate errors by not ordering early CTs in pancreatitis. We don't transfuse varices above a hemoglobin of 9. We never omit albumin in SBP. And we don't just assume a high SAG always equals cirrhosis without checking cardiac metrics first.
Let's put it all together. Imagine this ultimate test. A cirrhotic patient rolls in with altered mental status, severe hematemesis, an absolute leukocytosis, and an ambiguous ultrasound of the pancreas. You have to synthesize these raw limits perfectly. You sequence restrictive blood allocation for the bleeding. You push octreotide, and you recognize that the leukocytosis and altered mental status demand an immediate paracentesis to rule out SPP.
Which leaves us with one final provocative question. After you've stabilized those varices, what singular clinical variable dictates the immediate dosing of lactulose? It's that altered mental status. The gut is filled with blood, right? Bacteria break that protein down into massive amounts of ammonia, and the failing liver just can't clear it. That altered sensorium demands immediate lactulose clearance to trap and excrete the ammonia. It's a perfect loop of pathophysiology and targeted action. So, what are you going to prioritize on your next shift?